name is Deborah Ouimet, and I'm going to be speaking to you in a two-part series of trauma-informed care. I do not claim to be a physician, and I'm not dispensing medical advice. I'm synthesizing available information from literature for the purpose of teaching the behavioral health professional about treating clients with substance use disorders. What you will learn tonight is trauma-informed care objectives and principles, types of trauma, reasons for trauma, how to assess trauma, substance abuse and trauma, best practices for trauma therapy, transference issues, and self-care will be things we will learn on Thursday night. What is trauma? Trauma happens to most people. It's an injury or wound to a living tissue caused by an extrinsic agent, a disordered psychic or behavioral state resulting from severe mental or emotional stress or physical injury. It's an emotional upset. Trauma is unique to individual experience, and it's often seen in people who have gone through traumatic experiences in childhood, sexual trauma, global violence, global pandemics. Trauma is a factor in warfare and also in people that have had domestic violence situations. The trauma-informed approach, according to SAMHSA, is 6 key principles of trauma-specific interventions to address trauma's consequences. It realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others involved in the system. It responds by fully integrating knowledge about trauma into policies, procedures, and practices of the organization, and it actively seeks to resist re-traumatization for the client. SAMHSA's 6 key principles for the trauma-informed approach are instilling a sense of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historic, and gender issues with regards to trauma. Trauma-specific interventions are, according to the survivor's need to be respected, informed, connected, and hopefully regarding their own recovery, and not inflict any more trauma. The relation between trauma and symptoms of trauma, such as substance abuse, eating disorders, depression, and anxiety, are things to consider when assessing and working with the trauma client. The need to work in a collaborative way with the survivor's family and friends of a survivor and other human service agencies that would empower the trauma survivors and consumers. There are different types of trauma according to the DSM. There's post-traumatic stress disorder, and the symptoms of trauma are associated with the event of the trauma. And then there's complex trauma, also known as PTSD. This is also a developmental trauma that begins in early childhood and is the result of child maltreatment and neglect, and it can include psychological and physical changes to the person, and it also happens from physical abuse and witnessing domestic violence. PTSD, what happens when somebody is triggered with PTSD? Their heart beats rapidly, they get into a sweat, they feel cold and hot all at the same time, their hands and body extremities can go numb. They get what's known as tunnel vision. They start to only consider their own feelings and emotions and not with that which is outside them. Their brain shuts down, so their cognitive functions basically are just sensitive to their emotional feelings. And it's an awful thing to be in a trauma situation and feel this way, because it instills the freeze response in the body. And people often freeze in trauma and don't make wise judgments because of the state of being frozen in trauma. Then there's the normalization of trauma. When people are impacted by trauma after trauma, they normalize their symptoms and situations to get through them. In other words, if the parents yell and scream at the brothers and sisters daily, the child reacts by normalizing this, and their trauma tolerance goes up. So when they go into a home where everybody's nice to each other and there's no yelling and screaming, they feel out of place because they've normalized their trauma. And thinking errors start to develop. They may act in the future as if something bad is going to always happen to them, like a cloud is always hanging over their head. They develop yes, but thinking, always making excuses for their own poor behaviors or the poor behaviors of other people. They catastrophize. They exaggerate the cause and outcome of events. They use emotional reasoning and make decisions based solely on their emotions. Some common defense mechanisms of persons that have been in trauma are denial. Denial is the refusal to accept a reality or fact. It's acting as if a painful event, thought, or feeling did not exist at all. Then there's regression. Regression is the reversion of an earlier stage of development in the face of an unexpected thought or impulse. Then there's acting out. Acting out is performing of extreme behavior in order to express thoughts or feelings the person is incapable of otherwise expressing. People in trauma often dissociate. I've seen this happen with clients. Dissociation is when a person loses track of time and or person and instead finds another representation of their self in order to continue in the moment. They often can slip into even another personality during this time. Then there's compartmentalization. Compartmentalization is a lesser form of dissociation, wherein parts of oneself are separated from awareness of the other parts and behaving as if one had separate sets of values. So during the trauma, they compartmentalize, in other words, to keep functioning as an individual. Projection is the misattribution of a person's undesired thoughts, feelings, and impulses onto another person who does not have those thoughts, feelings, or impulses. Reaction formation happens. It's a converting of unwanted or dangerous thoughts, feelings, or impulses into their opposites. So in other words, a boss who is mean to an employee, the reaction formation for that employee would be to do everything right as to not anger the boss anymore and be kinder to the boss. Repression. Repression is an unconscious blocking of unacceptable thoughts, feelings, and impulses. The key to repression is that people do it often unconsciously, and so they often have very little control of it. Repressed memories are memories that have been continuously blocked from access or view. Then there's displacement. It's the redirecting of thoughts, feelings, and impulses directed at one person or object and take it out on another person or object. People often use displacement when they cannot express their feelings in a manner to the person that they want that to be directed at. So in other words, your employer is doing things to upset you, so you come home and you take out your anger upon your kids or your spouse. Intellectualization is the overemphasis of thinking when confronted with an unacceptable impulse, situation, or behavior without employing any emotions whatsoever to help mediate and replace the thoughts into an emotional human context. Rather than deal with the painful associated emotions, A person might employ intellectualization to distance themselves from the impulse, event, or behavior. Rationalization is putting something into a different light or offering a different explanation for things that have happened that are traumatic. Undoing is the attempt to take back an unconscious behavior or thought that is unacceptable or hurtful. Now we have some emotional trauma reactions that occur immediately and delayed. So when a trauma happens, there's often numbness, detachment. We see that usually in the form of denial. Then we have survivor guilt, anger, sadness, hopelessness, helplessness. And then feeling unreal, as if you're watching self, almost like an out-of-body experience. Depersonalization. You constrict your feelings. You tend to think with the logical mind instead of the combination of the emotional and logical mind. Behavior can be out of control. You can feel that things are out of control, and you feel overwhelmed, and you have a longer sense of a denial period. Then there's some delayed emotional reactions that happen as a result of trauma. Depression, mood swings, instability. These can happen at any time after a trauma occurs. Fear of the trauma reoccurring, anxiety, feeling of vulnerability, feeling of fragility, grief, emotional detachment from anything that requires you to have an emotional reaction. Some of the physical reactions to trauma are immediate and delayed. The immediate reactions are nausea, gastrointestinal distress, sweating, shivering, faintness, muscle tremors, elevated heartbeat, respiration and blood pressure, extreme fatigue, greater startle response, and depersonalization. The delayed physical reactions that can happen at any time after a trauma are sleep disturbances, nightmares, somatization, that's increased worry about body aches and pains that weren't there, appetite and digestive changes, lower resistance to infections, fatigue, elevated cortisol levels that result in hyperarousal. Some cognitive reactions to note that happen as a result of trauma are immediate and delayed. The immediate ones are difficulty concentrating, racing thoughts about the event, distortion of time and place, memory problems, strong identification as the victim, and strong identification with others who have also been victimized in that trauma. The delayed cognitive reactions that happen could be intrusive memory or flashbacks, reaction of self-blame in the event, preoccupation with the event, always talking about it, always thinking about it, difficulty making normal everyday decisions, magical thinking, belief that doing certain things will prevent the trauma from happening again in the future, and a generalization of the trauma. We see that the trauma is then generalized and it almost starts to be normalized. The behavioral trauma reactions are important to note, especially among substance abuse counseling. They're immediate, they're startled reactions, restlessness, sleep and appetite disturbances, difficulty with self-expression or thought or content, argumentative, increase of substance use, avoidant behavior, and apathy. The delayed behavioral reactions include avoidance of event reminders. They like to avoid anything that would remind them of the event. There's social relationship disturbances, the ability to not want to go out anywhere, to not see certain people, to isolate, to stay alone. Decreased activity levels, they don't want to do things that they normally used to like to do. Engagement in high-risk behaviors, the opposite. They want to do everything that they couldn't do before, and they often take very high risks in doing that. There's increased substance use. There's isolation and withdrawal. Existential reactions to trauma are things that happen immediately and delayed. For immediate, it's the intense use of prayer, a restoration of faith, some loss of self-efficacy, despair with humanity in general, immediate disruption of their life value system. The delayed existential reactions are questioning, why me, why now, why this? Increased cynicism, disillusionment with life in general, loss of purpose. There is a renewal of faith or a disillusionment with faith. Hopelessness, reestablishing priorities, reworking life priorities to accommodate the trauma, taking self-defense classes, or increasing self-protection. Complex trauma is something that begins in early childhood. It's chronic. It occurs in the child's primary caregiving setting, system, or social environment. Exposure to trauma results in emotional dysregulation, loss of safety, direction, and the ability to respond to danger clues. This impacts the child's welfare and can lead to repeated re-exposure to trauma later in life. Other related trauma diagnoses include acute stress disorder. After exposure to actual or life-threatening death, serious injury, or sexual violation, a person may have recurring dreams, nightmares, flashbacks, or intense or prolonged psychological stress related to the trauma. This does not note that they have PTSD, which is a different set of diagnostic criteria, but they have acute stress related to the trauma. Adjustment disorders, the development of emotional or behavioral symptoms in response to an identifiable stressor occurring in the first 3 months of the onset of the stressor. So this is adjustment disorders. Could be when somebody moves to a new place. They have a slight adjustment disorder. Parents go through a divorce, or adults go through a divorce. There's adjustment disorders. It can be behavioral. It can be seen in children who transfer schools. They have adjustment disorders. Other trauma and stressor-related disorders are symptoms that are characteristic of trauma and stressor-related disorders that cause significant distress. Some of the causes of trauma that we will review are domestic and intimate partner violence and sexual violence in youth, child abuse and neglect, elder abuse, youth violence, global violence, suicide, accidents and injuries, and natural disasters. Intimate partner violence. Intimate partner violence occurs everywhere in the world. There is now a large body of research demonstrating that experience abuse by an intimate partner is associated with a wide range of health and mental health consequences. Some are the direct results of physical and sexual violence. Others are related to traumatic, psychophysiological effects of ongoing abuse. Both clinical and population-based studies indicate that victimization by an intimate partner places people at significantly higher risk of depression, anxiety, post-traumatic stress, somatization, medical problems, substance abuse, and suicide attempts. In addition, there are higher rates of intimate partner violence among people accessing services in health and behavioral health settings. There are some intimate partner violence definitions that you should become familiar with. Coercion is the use of force or manipulator to control an intimate partner's thoughts, actions, and behaviors through violence, intimidation, threats, degradation, isolation, and/or surveillance. There's mental health coercion, which is abusive tactics targeted towards a partner's mental health as part of a broader pattern of abuse and control, may involve the use of force, threats, or manipulation. In the context of intimate partner violence, coercion can involve financial, psychological, physical, sexual, and other kinds of abuse to undermine and control an intimate partner. In mental health coercion, they can include deliberately undermining a survivor's sanity, preventing a survivor from accessing treatment, controlling a survivor's medication, using a survivor's mental health to discredit them with sources of protection and support, leveraging a survivor's benefits to manipulate or their condition to manipulate police or influence child custody decisions, engaging mental health stigma to make a survivor think it's their fault and that nobody will believe them. Intimate partner violence is a serious, preventable public health problem that affects millions and millions of Americans. The term IPV describes physical, sexual, and psychological harm by a current or former partner or spouse. This type of violence can occur among heterosexual and same-sex couples and does not require sexual intimacy. There's IPV findings from the National Coalition Against Domestic Violence. These are current and to date. More than 10 million Americans are victims of physical violence annually. 20 people are victims of physical violence every minute in the United States. 1 in 3 women and 1 in 4 men is a victim of some form of physical violence by an intimate partner during their lifetime. 76% of intimate partner physical violence victims are females, 24% are males, and this number is continually rising. 1 in 7 women and 1 in 18 men are severely injured by intimate partners in their lifetimes. Domestic violence accounts for 15% of all violent crime in the United States. Domestic violence is most common among women aged 18 to 24 and men aged 25 to 34. A majority of physical abuse is committed by dating partners rather than spouses. So as clinicians, we should know how to do domestic violence screenings. I've provided some of those in your packet, and we will go over them in our subsequent slide series on Thursday. We should do an initial danger safety screen if someone talks to us about intimate partner violence. It should be part of our intake and assessment plan. It should be an intake and brief safety plan. We should always have a domestic violence follow-up. It should be part of any mental health assessment we're doing. And if there is domestic violence present or IPV present, we need to have an extended safety plan with that client. So there's some prevalent mental health and substance abuse issues that are targeted in the mental health coercion that we talked about earlier. 85.6% of people with dual diagnosis said that a partner or ex-partner had called them crazy or accused them of being crazy. 73% said the partner or ex-partner had deliberately done things to make them feel like they were going crazy or losing their mind. Over 53% said that in the last few years they had gone to see someone like a counselor, social worker, or therapist, and 49% said that their partner tried to prevent them or discourage them from getting help or using the medication for their mental health or substance use concerns. 50% said that a partner or ex-partner threatened to report to authorities that they were crazy to keep them from getting something they wanted or needed: children, medication, protection orders, etc. Prevalent mental health and substance abuse issues are targeted. So we have to look at how people use substance abuse in mental health counseling scenarios. They use substance abuse to numb the pain of the abuse. Using alcohol or other drugs is a way to reduce the pain of their partner abuse. Coercion. The partner or ex-partner has pressured or forced them to use alcohol or other drugs and made them use more than they wanted. They do this by buying it for them, by enabling them, by telling them they like them better when they're high. They control their partner by trying to prevent or discourage them from getting help. Look how many times you relapse. Nobody's going to want to help you now, or you're too crazy to get help. I love you just the way you are. They use fear and victimization. Partner or ex-partners threaten to report their alcohol or drug abuse to someone in authority to keep them from getting the help they needed. In other words, if you go get help, they're going to find out that you've been drinking and you have your kids, so you're going to lose your kids. There's fear and intimidation. They're afraid to call the police for help because they feel that they won't believe them because they were using or they have mental health problems. The cage aid is a tool you can use when you feel that there's substance use disorders present in the mental health setting and also in the clinical setting, and we will review that on Thursday. Substance abuse coercion. Abusive tactics towards the partner's substance use as part of a broader pattern of abuse and control. This involves the use of force, threats, or manipulation that include forcing a survivor to use substances or to use them more than they want to. It's a control pattern for people that are abusers. They need to feel needed, so they will buy the substance users drugs or alcohol. They will provide them with it. They will tell them they like them better on it. They will start using it with them. They will make it more available. Using a survivor's substance abuse to manipulate police or influence child custody decisions, or deliberately sabotaging their recovery efforts and access to treatment, or engaging substance abuse to make the survivor think that no one will believe them. This is something that happens all of the time in substance abuse counseling when you start to counsel families. Again, use the cage aid as a screening tool. So for routine inquiry and assessment, providers can ask about mental health and substance abuse coercion as part of their routine behavioral health histories. They can include questions about the connection between a person's relationship with their partner and their mental health and/or use substances. They can create an opportunity for someone who is experiencing intimate partner violence to begin to think about how these issues might be connected for them. They can ask IPV questions, allowing clinicians to provide more appropriately tailored counseling, treatment, and referrals. Given that some of the forms for treatment might not be acceptable for someone who is in an abusive relationship, they can leave them around the office. You can have accessible forms in your waiting room. You can have them in your screening tools, and you can provide them with access to phone numbers for forms online. How do we assess trauma? Trauma is assessed when we do our first psychosocial. It usually has to be done by a social worker for a full diagnosis or a licensed professional counselor. But we always want to talk about trauma with our clients because it's an important part of the recovery process. We ask about the relationship of their mental health symptoms to their current abuse and previous trauma, including the relationship between a person's mental health and their overall experience of intimate partner violence. We discuss their trauma. We talk to the patients about how their feelings of anxiety or depression, their experience of PTSD, their difficulties in trusting other people, and challenges in managing their emotions correlate with their substance abuse counseling. We consider the relationship of their experience of living in fear, entrapment, economic control, physical violence, sexual coercion, or injury-related disability, chronic pain as part of their substance abuse counseling. We often assess the relationship of the mental health issues to mental coercion. Ask how they are feeling when no one will take them seriously. Being afraid to call police because they will be arrested or committed to a psychiatric unit. Being afraid to leave because they won't be able to get custody of their children. How they feel about having suicidal thoughts, being terrified or terrorized, experiencing despair or doubting their perceptions of reality. Relate to experience of mental health coercion, such as being exposed to constant gaslighting, manipulating someone to make them question their memory, experience, or sanity, or to a partner who keeps them from sleeping, prevents them from accessing treatment or medications, undermines their credibility with others, or threatens them with commitment, deportation, or loss of custody. For example, depending on what the person shared with you, you can ask, I wonder how feeling depressed might be connected to the names you've been called and the way you have been treated with disrespect. You can always ask them how they feel and what the connection is. Ask about how their partner responds when they are symptomatic. Is your partner supportive of your mental health or substance abuse issues? Does the partner use their mental health condition to justify abuse? Does their partner try and control their medication or treatment? Is their partner only kind to them when they are abusive or unsupportive, or when they are feeling good or in a crisis? Part of things we do in the substance abuse field is to help our clients learn to use medication and to write this into our treatment plans. So in part of screening for trauma, we can write the trauma goals also in their treatment plans. Ask how the person thinks that their partner might respond to their treatment. Do they want them included in their treatment? Does their partner know they are receiving treatment? What's the potential for medication side effects to place them at greater risk at harm at home? Does the person need to try and help figuring out how to protect themselves if their abusive partner interferes with their treatment or prevents them from taking medication or coerces them into taking too much medication? The key elements for responding to mental health and substance abuse coercion in clinical practice is to ensure that all clinical and non-clinical staff receive training on trauma and intimate partner violence. It's to incorporate questions about coercion and IPV into routine intake and assessment procedures. Know how or when your state requires reporting of intimate partner violence. Acknowledge impact and express concern. Address immediate and ongoing safety needs, including security, psychiatric advance directives, and family involvement in treatment. Work in partnership with survivors to develop safe strategies for addressing coercive behaviors and their effects. Provide access to print and online resources on trauma and intimate partner violence in your waiting rooms and lobbies. Document the ways that link symptoms and the ability to participate in treatment to the abuse. Document efforts to protect and care for the children. Provide linkages or warm referrals to community IPV resources, including legal and hotlines. Incorporate IPV counseling and safety planning into the clinical treatment and other services, including medication decisions, overdose and relapse prevention, mental health, substance abuse, and trauma treatment. Discuss confidentiality and duty to warn. Incorporate responses of IPV and other trauma into performance improvement from people who are experiencing IPV. Ensure that services are both IPV and trauma informed, and one owns responses and need for consultation and support is something that is ongoing in the treatment setting. We're going to talk now a little bit about sexual violence. Sexual violence is a significant problem in the United States. It refers to sexual activity when consent is not obtained or given. Anyone can experience sexual violence, but most victims are females. The person responsible for the violence is typically male, but not always, and usually someone known to the victim. The person can be, but is not limited to, be a friend, a coworker, a neighbor, or a family member. CDC, the Center for Disease Control, uses a 4-step approach to address public health problems like sexual violence. Define the problem. Identify the risk and protective factors. Develop and test prevention strategies. Assure widespread adoption. So some of the sexual violence statistics, according to CDC, is that approximately 8% of an estimated 10 million girls are experiencing rape or attempted rape. About 4% of an estimated 4 million have experienced rape involving drugs and alcohol. For boys, 7% is an estimated 791,000 experience either rape or attempted rape, and 4% estimated that they experienced rape. Almost 2% of boys, 2 million, were either made to penetrate someone or there was an attempt to penetrate them. 1%, or an estimated 1 million of girls, experienced to be made to penetrate involving drugs and alcohol. Now we have military sexual trauma. If we see veterans in our programs, this can happen to them or could have happened to them. An average of 1 in 4 female veterans and 1 in 100 male veterans in the VA health system report suffering from military sexual trauma. Military sexual trauma is being threatened or persuaded into sexual activity, better assignments, other promises regarding tours of duty. Sexual harassment or contact without your consent while being intoxicated, asleep, or awake. Being physically forced to have sex. Touched in an uncomfortable manner. Repeated comments about your body or sexual activities. Threatening and unwanted sexual advances. There are different abuser styles. This list is from Lundy Bancroft's book, I Don't Want to Live Like That Anymore, Inside the Minds of Angry and Controlling Men. The demander. It's a victim's job to keep them happy and to cater to their needs. Their mindset is, I'm loving and giving, you're privileged to have me. The I'm always right is the more intelligent, superior, and is always right, the one that intellectualizes. The water torturer, the victim must be crazy. He does all he can do to get the one who's abused stirred up with perfect calmness and convinces their partner that he or she is the abuser. Then there's the drill sergeant. They're extremely controlling and directing. They watch their prey like a hawk. They proclaim they love the victim more than anything else, and they're very possessive. The I'm sensitive controls the victim by analyzing their mind and seems to know how the emotions work. The abuser will get inside the victim's head whether they want them there or not. You should feel grateful because I'm sensitive and not like other people is their mindset. The player, they are put on this earth to be irresistible to the opposite sex. Their idea of relationship is not one of commitment. Their partner is not entitled to think. They have the freedom to move around sexually with whomever they please, but hold their partner very close to them. The victim, Everybody has done them wrong, especially the opposite or same sex. When you accuse me, you join the parade of people who have been cruel to me my whole life. All my actions and abuse are justifiable because of my past pain. I'm not responsible for any of my actions of abuse towards you. The terrorist, you have the right to defy or leave me. You have no right, to defy or leave me. Your life is in my hands. I would rather die than accept your right to independence. Seeing you terrified is exciting and satisfying. Mentally ill or addicted abuser. They don't really feel responsible for their actions because of their psychological or substance abuse problems and often use them as an excuse for their violent behaviors. They feel like the victim and often feel worse mentally that causes them to use alcohol or drugs in their mind, and they lord this over their intended victims, and that's how they get away with rationalizing their abuse. Child abuse and maltreatment is neglect of anyone under 18 by a parent, caregiver, or another person in custodial roles. There are 4 common types of maltreatment for children. Physical abuse, where they're hit, beat, hit with cords, hit with objects. Sexual abuse, where they're either touched or fondled in a sexual way, or they could have penetration and could be sexually assaulted. There's emotional abuse, where they're denied access to speaking about their emotions or treated in a negative way by their parents. And there's neglect, failure to provide food, clothing, shelter, or housing. The types of child abuse in the United States, we see the highest is neglect, 78.3, according to the Department of Health and Human Services. Physical abuse is the next highest, 17%. Psychological maltreatment or emotional abuse is 8%, and sexual abuse is 9%. There's some facts about child abuse and neglect. According to the governmental studies on child abuse and neglect, 3.5 million children who were subject to an investigation or alternative response in the fiscal year of 2017, an estimated 674,000 children were determined to be victims of maltreatment. That was down from 2016. There's an increased number of child fatalities due to abuse and neglect in the fiscal year of 2017. The estimated referrals to CPS for investigation or response for alternative response were 15% up from the year 2013. The total lifetime cost of child abuse and neglect is an estimated $124 billion each year in the United States. Elder abuse. Elder abuse is the intentional act or failure to cause and creates a risk of harm to an older adult. That older adult is someone age 60 or older, and in some states it's over 65. The abuse occurs from the hands of a caregiver or a person the elder trusts. 5 frequently recognized types of elder abuse include physical. This occurs when an elder experiences illness, pain, or injury as the result of unintentional use of physical force and includes acts such as hitting, kicking, pushing, slapping, and burning. Sexual. This involves forced or unwanted sexual interactions of any kind with an older adult. This may include unwanted sexual contact or penetration of non-contact acts such as sexual harassment. Emotional and psychological. This refers to verbal or nonverbal behaviors that inflict anguish, manipulation, pain, fear, or distress of an older adult. Some examples include name-calling, humiliating, destroying property, selling property, or not letting the older adult see family or friends. Neglect. This is the failure to meet the adult's basic needs for food, water, shelter, clothing, and hygiene, and essential medical care. Financial, this is legally or improperly using the elder's money, property, or assets for the benefit of someone other than the elder, and taking money from the older adult's account without proper authority and card use, and exchanging a will without permission of the elder. Youth violence is a prevalent problem in our society. It's a significant public health problem that affects thousands of young people each day in their families, schools, and communities. Another form of youth violence is bullying. And youth violence can include fights, threats with weapons, gang-related violence, cyberbullying, and basically sexual violence. Youth violent facts. Worldwide, some 200 homicides occurred among youth ages 10 to 29 each year, 43% of the number of total homicides globally each year. Homicide is the fourth leading cause of death in people aged 10 to 29 years. 83% of these homicides are male victims. For each young person killed, many more sustain injuries requiring hospital treatment. In one study, 3 to 24% of women report that they had their first sexual experience that was forced in their youth. When it is not fatal, youth violence has had a serious, often lifelong impact on a person's physical, psychological, and social functioning. Youth violence greatly increases the cost of health, welfare, and criminal justice services. Interpersonal gang violence kills more people than political violence. 500,000 people are killed each year by interpersonal gang violence, and more than 1,300 people per day is more than 9 times those killed in warfare. This craft screening tool is something we can use with youth to talk to them about some of the emotional things that are going on with them, as well as the substance use concerns. The CRAFT stands for C. Have you ever ridden in a car driven by someone, including yourself, who is high or has been using alcohol or drugs? R. Do you ever use alcohol as a way to relax, feel better about yourself, or fit in? A. Do you ever use alcohol alone or drugs alone? F. Do you ever forget things you did while using alcohol or drugs? F. Do your friends and family ever tell you that you should cut down on your drinking and drug use? T. Have you ever gotten in trouble while you are using alcohol or drugs? This screening tool is provided in your screening packet, and we can go over it in more detail on Thursday night. Gun massacres and gun violence. Americans killed by gun violence from 2014 to 2017 is over 56,000. Americans killed by guns in 2017 was over 15,000. Children under the age of 12 who were killed or injured by guns is over 2,000. Mass shootings from 2017 to 2014 to 2017 is over 1,300. Mass shootings so far in 2018 have been 30. Mass shootings on school grounds from 2014 and 2017 have been 8. Global violence. This is something else that occurs. Violence occurs more than 1.6 million deaths worldwide every year. More than 90% occur in low and middle income countries. Violence is the leading cause of death in all parts of the world for persons ages 15 to 24. We've recently had in 2020 a global pandemic, and that evokes fear and after effects and can be traumatic. After 9/11, we did studies of mental health and how it impacted the United States, and we found that there was a higher incidence of PTSD reactions in the general population. There was a heightened sense of vulnerability. We felt more vulnerable as citizens to terrorist attacks. There was anger. There was religious and cultural intolerance that happened. There was also an increase or decrease in patriotism. There was a desire to remain closer to family and friends, and technology moved in and started facilitating online interpersonal reactivity between people to help with the social distancing that people were feeling and the need to isolate because of global violence. So what can we expect as caregivers after COVID-19? Well, we've already seen some atypical buying patterns, compulsivity and hoarding. We've seen a toilet paper shortage. We're seeing a meat shortage due to COVID-19. Increase in self-sufficiency. We're seeing more people starting to become self-sufficient or prepared for more global pandemics. There is more social distancing. Even though some states have lifted the rules, we still feel the need to socially distance. There has been increased isolation, anxiety, anger, hopelessness, grief, possible increased suicidal behaviors, although a study has not been thoroughly conducted as yet. There's an increase in addictions, poverty, PTSD reactivity. People are becoming more symptomatic. There's a burnout for healthcare workers. Those who are on the front lines are going to be experiencing PTSD, and we're going to see how we need to treat their burnout after this. War, terror, and violence are some other post-traumatic stress reactors. Global trends in armed conflict. In 1980, there were less than 60,000 battle-related deaths compared to 110,000 in 2013. In 1989, there were less than 10,000 terrorist casualties as compared to 45,000 in 2013. And in 2015, the number of ongoing conflicts increased from 50 compared to 41 in 2014. These are studies from the Conflict Database, Global Terrorism Database, and the Institute of Economy and Peace. Suicide is also a factor in trauma. If persons have committed suicide in the past or tried to commit suicide or had family members or friends that have, this always impacts trauma reactivity in our patients. The age-adjusted suicide rate in 2017 was 14 per 100,000 individuals. The rate of suicide was the highest in middle-aged white men in particular. In 2017, men died by suicide almost 4 times more often than women. On the average, there are 129 suicides per day. White males accounted for over 69% of suicide deaths in 2017. In 2017, firearms accounted for 50% of all suicide deaths. Suicide is definitely a major health problem. Here are some suicide risk factors we can look at when we're screening our patients or counseling them. Have they had any previous suicide attempts? Is there a history of depression or other mental illness? Do they have alcohol or drug abuse problems? Is there a family history of suicide or violence? Do they have any physical, life-threatening illness? Do they feel alone? Suicide affects everyone, but some groups are higher risk than others. Men are about 4 more times more likely than women to die from suicide. However, women are more likely to express suicidal thoughts and non-fatal attempts than men. The prevalence of suicidal thoughts, suicide planning, and suicide attempts is significantly higher among young adults aged 18 to 20 years. Accident and injury. Accident and injury, even a car accident, is a cause for trauma. The number of medically attended injury and poisoning episodes in the population was 39.5 million. The number of emergency department visits for injuries related to accidents was 42 million. The accident and injury can cause a traumatic reaction. Look for signs of memory loss, irritability, sadness, lethargy, poor appetite, and sleep, lack of interest in daily. Natural disasters are another cause of trauma. Flood, fire, tornadoes. During, at, and after a disaster, it's natural to experience different and strong emotions, shock, trauma. Some of these natural disasters can include earthquakes, flood, tornadoes, hurricanes, landslides, snowslides, mudslides, extreme heat or cold, wildfires, tsunamis, and lightning. Signs of stress after a disaster. Look for these common signs of distress in persons: feelings of shock, numbness, disbelief, changes in energy and activity levels, difficulty concentrating, changes in appetite or sleep, nightmares, upsetting thoughts or images, feeling anxious or fearful, sleeping problems, physical reactions such as headache, body pain, somatization, stomach problems, skin rashes, chronic health problems can get worse. Changes in use of alcohol, tobacco, or other drugs, short-tempered or angered easily. Now we're going to talk about a little bit what happens to the clinician with vicarious trauma. Transference and countertransference. According to Powell, transference is defined as an irrational attitude manifested by a patient towards a counselor or others in a way that is not evoked by realities that are present. It is derived from the patient's relationship with someone past or present. So in other words, you can remind your client of someone that was abusive to them in their past or whom they have had a negative interaction with. That's what transference is. Countertransference. According to Perlman and Sakvitny, transference refers to an unconscious repetition in a current relationship of patterns of thoughts, feelings, beliefs, expectations that originated in an earlier important relationship. The definition of countertransference includes two components: an effective, ideational, and physical responses of a therapist has towards their client, their clinical matter, and transference and reenactments. 2, the therapist's conscious and unconscious defenses that affect the interpsychic conflicts and associations aroused by a former. All the client responses and our responses to the client arise in the context of our role of professional identity as a therapist and the unique nature of the therapeutic relationship in our own personal history. So the client, in other words, can remind us of someone in our past whom we may have had a traumatic reaction from. So that is transference and countertransference. We have to look at how we can process that. I have had both issues happen to me in my career. Transference often happens when you remind clients again of somebody that is in their past that they have not had good interactions with, and countertransference is when clients remind us of someone in our past. Indications of countertransference. This happens for the clinician when they get a feeling of loathing or dread from the prospect of having a session or even seeing the client. Unexplained anger or rage at the client. Intense feelings of guilt or shame if the client does not seem to be getting anywhere in the counseling or relapses. Chronic feelings of helplessness and inadequacy in relation to the client. A sense of scatteredness, fragmentation, or dissociation when working with the client. Feelings of being victimized by the client. Pressured feeling in the chest, knots in throats, tightness in neck or shoulders, etc. when working with the client. cutting our sessions short, allowing sessions to go way over the time, and sometimes canceling appointments unexpectedly with the client for no apparent reason. Anxiety and fear of exploring trauma material with that client. A respectful method for exploring clinical countertransference is examine the extent to which the clinician's reaction to the client facilitates or inhibits their empathy for the client. Examine the extent to which the countertransference reaction may have been intensified due to the clinician's vicarious traumatization or secondary trauma reactions. We can wear our client's trauma. Devise a strategy for addressing the countertransference issue. I'm just going to talk a little bit about some of the ways that this has affected me. I've had many countertransference issues, gotten through all of them because I've had good help and good clinical supervision, but I always know to bring them to my supervisor. Early in my career, when I was working with clients who were opiate dependent in a methadone clinic, there was a countertransference situation. I felt very badly for a client that was very down on her luck, was about to lose her housing, didn't have any money. I would often go to the window and talk to them about extending her financial payment plan. I would frantically look for resources for her on my own time, often calling her at home and telling her about these resources for a food pantry. I just wanted to make sure I was doing my job, and I was becoming overly conscientious. My supervisor got wind of it and was able to help me through this, and I had to look at my own reactivity, because I was once too a single mom that had some of these financial things happening to me, and I didn't have enough money. So it was definitely part of my own story, and I was taught ways to step back and react differently when in session with her, and try and identify with her in a different manner. So we devised a strategy for addressing the countertransference issues. I was doing more work than she was to manage her poverty, and that's something that my clinical supervisor pointed out to me. So when she came in for the next session, instead of telling her all the resources I had found for her, I explored having her tell me what her current resources were that she had found, and she hadn't found any, so she wasn't really interested in helping herself as much as I was interested in helping her. So it's some advice to counselors to decrease the secondary trauma and promote self-care. We can indeed get secondary trauma for our clients like I just described. Our client can go through a relapse, and we can feel that relapse. We can feel the pain of that relapse. Or they can experience a death in their family, and we're saddened for them in such a way that it becomes sympathetic and not empathetic. Always have your sympathetic hat put away and take your empathetic hat, so you're not jumping in the boat with your clients. One of the things we can do is have good peer support. Make sure there's always other counselors you can talk to about these things. Maintain adequate social support to help prevent isolation and depression for yourself. So make sure you're getting out with friends and family, doing self-help meetings if you need to. Always have supervision and consultation handy, being willing to go talk to your supervisor at any time. Have training like this. Ongoing trainings, definitely professional trainings, help us ward against secondary trauma. Have personal therapy if you need to get past some of your own traumatic reactions. Maintain balance in your life by eating well, sleeping well, getting plenty of exercise and family time, and taking those adequate vacations that we all need, because vacation time is important for our wellness. So if we're going through something that's tragic in our lives, we might want to talk to our supervisor and get time off prior to coming back to work so we can get through that and we can be well when we're dealing with our clients. I hope this was informative, and I look forward to seeing you on Thursday night for our Zoom meeting to go over some of the forms of therapy for trauma clients and some of the assessments. If you have any questions, please feel free to bring them to the Thursday class. Have a great evening.